Righty. Well, it is 10:02 for me, so I think we will go ahead and get started. Good morning, everyone. My name is Eileen Saunders. I am with the Department Waiver Innovation Unit Supervisor, and you are attending the Community First Choice Council meeting for December. So welcome. Thanks for joining us today. Alrighty. And then Julie, if you can go ahead and get the recording started, that would be great. We do record these meetings and post them on our CFC Council webpage. All right, I can move the slides along. Okay, here we go. So our mission at the Department of Healthcare Policy and Financing is healthcare equity, access, and outcomes for the people we serve while saving Coloradans on healthcare and driving value for Colorado. Okay, so today we are just here for an hour, so we don't have as long of an agenda, as we typically do. We'll be going over kind of our CFC overview and our enrollment numbers, and then we will go over our direct care services calculator and protective oversight updates. And then we will be going through sustainability actions that impact Community First Choice specifically, and the rule change timeline to expect for those sustainability actions. And then lastly, we'll go over our difficulty of care fact sheet. All right. As always, please refrain from sharing any protected health information. As I mentioned, we do record these meetings and post them on our CFC Council webpage, but we are unable to do so if there is any protected health information shared. So please refrain from sharing any PHI. And then if you have any, if you need any accommodations, such as translation services, please reach out to our civil rights officer. Their email is hcpf504ada@state.co.us. And we typically need about a week prior to meetings to make those arrangements. Okay. So if you have, if this is your first time joining us, welcome. I typically just do a quick overview of Community First Choice for any of you who are new. So Community First Choice, or CFC for short, is a state plan program that states can choose to implement. And it is a program that lives within the state plan, and it allows states to take certain HCBS waiver services out of those waivers and into Community First Choice on the state plan, where they are accessible to all waiver members, regardless of their waiver, and to eligible members on the state plan. So it expands access to more members and allows kind of easier, quicker access to these services than if they were on the waiver programs. The CFC does not require the targeting criteria that the HCBS waivers do, but it does require members to meet that institutional level of care. So that baseline level of care that is needed or conducted via the ULTC 100.2. So the services that we have brought over into Community First Choice are on the left-hand side of this slide. As of July 1st, 2025, when we launched the program, we brought over homemaker, personal care, health maintenance activities, remote supports, home delivered meals, physician setup, personal emergency response systems, and medication reminders. And then our two participant directed service delivery models, in-home support services, or IHSS, and consumer directed attendant support services, or CDOS. So regardless of your waiver program, members can access either of these participant directed service delivery models if they would like. It's really exciting. Okay, so currently, since July, we now have almost 15,000 CFC members enrolled, which is really exciting. So we're on track numbers wise for gradual enrollment throughout the transition year. And we have roughly 500 CFC only members, so members who are just on CFC and not utilizing a waiver program. We also have almost 900 children's home and community-based services waiver members who have transitioned to the new children's waiver, the children with complex health needs waiver. And then, as you'll recall, all members who were on the children with life-limiting illness waiver were automatically enrolled into the new children with complex health needs waiver on July 1st. So again, enrollment into the new children's waiver is moving along as expected, which is great. Alrighty. So now we're going to pivot into protective oversight and difficulty of care changes. Well, actually, sorry, let me pivot back really quick because I forgot that I wanted to make a quick plug during this part of the slide. So if case managers, members, if anyone on this call is experiencing any enrollment issues, please do not hesitate to reach out to us at the CFC inbox. We'll post our email inbox at the end of this presentation. We definitely always want to hear how things are going. This is a new program, a lot launched in the summer. And so we definitely want to hear from you if there's anything going along that doesn't seem expected. So please feel free to reach out to us. We will direct your case in the right direction if we need to, but that's how we kind of hear of anything that might be going wrong or anything that we might need to fix. So it's really helpful for us when we get to hear from you on how things are going. And then the other plug I'll just make quickly is for enrollment timing. Members do enroll into CFC. Current HCBS waiver members who are enrolling into CFC do so at their regularly scheduled continued stay review. So throughout the transition year from July 1st, 2025, when we launched, to June 30th of 2026, members will enroll into CFC with their case manager at CSR. If members want to enroll before their CFSR, they can do so if they have a significant change in condition. And if you have any questions about that, please reach out to us. We and our case management team can help members and case managers with any cases that you might have questions about. So I just wanted to make that plug and that reminder to reach out to us if you have any questions. And yeah, all right, we will move along. Oh, Lana, go ahead.
Hey, Eileen, sorry to interrupt. We have our case management team on the call as well, and they wanted to also provide a reminder that we have the escalation form that can be utilized if a member or a family or anybody would like to submit an escalation or a complaint to the department. That's a really effective way for those types of information to come to us because we track them in a really specific way. So Kidron, I saw you came off camera. Did you have anything you wanted to add to that?
No, I just wanted to come on camera if people had any questions about that. And thanks for adding that, Lana. Appreciate it.
Yes, thank you so much. Appreciate that. Okay, great. Alrighty, well, I will move on to the next slide. And if we have any questions about enrollment, we can take those during open forum at the end of the presentation. Okay. Let's see. So we have, we wanted to go over a couple changes. The first one is for our direct care services calculator. This calculator is a new calculator specific for CFC direct care services, personal care, homemaker and health maintenance activities. And it was launched with the launch of CFC to help calculate hours for these 3 services. We have recently revised the definition of this calculator in our regulations to specifically reference our age-appropriate task standards. So we have the edited definition here on the slide with the new language underlined and bolded. And so the addition that you see here is for the age-appropriate task standards for children and for adults. So we have changed the term from norms to task standards to be a little bit more specific, as you know, personal care, homemaker, and health maintenance have specific tasks within them that case managers look at for their members when they're conducting service planning. And so we wanted to be more specific when we're talking about tasks in reference to age appropriateness. And so the calculator will also include task definitions, task times, standard task times, including maximum times permitted. And then for children, we have age appropriate task standards that must be followed, which is referenced in our regulation. And then we also have a health maintenance activities documentation guide. So all of these reference materials, which I believe are now included as tabs in the direct care services calculator paper Excel version, they will be posted, or instructions for more details on how to use each of these reference materials will be released soon along with a memo. So yeah, I see a hand up now. I'll take questions in just a minute, but I wanted to check in with Lana on the chat to make sure I didn't skip ahead if there was anything we wanted to address in the chat.
Thanks, Eileen. There's a question about if the DCSC is being used for HMA.
That's a great question. I will double check with Cassie just to make sure, as I know guidance has shifted in the last month or two to make sure that I'm not saying anything that I shouldn't there. Okay, Cassie, it's not. Thank you. Appreciate it. So currently HMA is not being used with the direct care services calculator. Okay.
I think we'll work through the chat questions via chat if we want to go to Jose.
Okay, perfect. Go ahead, Jose.
Thank you, Eileen. I have a question about the calculator. Is this calculator usable for IHSS and CDAS? Only CDAS, or how does that work? And do you have a version online?
Yes, so this calculator is used for all members who are using IHSS and CDAS, although the CDAS, and you know, Danny, you can jump in, correct me if I'm wrong, but case managers will still kind of go through their CDAS planning in their documents as they typically would, but this calculator is kind of like step one, if you will.
And do you have a version online?
Yes, so there is, the calculator is posted online in an Excel document format. And then the actual calculator functionality, so what case managers enter officially into the Bridge system, exists in the Bridge for case managers to use, but it's the same document that exists online in an Excel format. But we provide those Excel paper versions, if you will, for case managers to use when they're talking with their member.
Would it be possible for you to share the link of where we can find the Excel Because I think I have the old one, the really old one that we used to use in CDAS, but I don't think I have the one that you guys are referencing.
Absolutely, yes, we can drop the links to the direct care service calculator, the Excel version, in the chat.
Thank you, Michelle. I see it.
Yeah, of course. And if Danny or Rachel, someone on my team, or Danny, if you have a link to that, that would be great. Oh, Danny, go ahead.
Oh, yes, apologies. I think I can provide the link, but I also did want to just clarify too that we are really just trying to inform the group of the changes that have already occurred and that are coming up. And so the direct care services calculator was an emergency rule that was presented and was adopted in November. And so as of now, we're informing the group that this is what has occurred and letting you know what changes you might be expecting, but we're not necessarily soliciting open-ended feedback about updates to the form and things of that nature, but just know that the information will be provided as it becomes available.
Perfect. Yes. Thank you, Danny. Okay. And that same sentiment goes for the next slide, our protective oversight update, which we brought as emergency rules on the same date, November 14th. As the change to the direct care service calculator. So we're informing the group that we have revised the definition of protective oversight in our regulations, and that has happened, and that new definition now clarifies what is and is not permitted in protective oversight. And if you would like to review that full definition change, you can do so in the MSB document. We have it linked. I believe that's a link. Maybe it's not, but either way, we can link it to you in the chat for the MSB document if you would like to review that definition in full. But essentially, we provide additional information for approving this task for children as it was not previously outlined in rule, and we have included rights modification information, and that there must be a documented evidence of risks requiring regular and predictable intervention within the past year. So again, we will continue to provide more information on the maximum time permitted for tasks, including protective oversight. So more information will come about that soon. Okay, any questions about this one? Okay. Great. And then again, we have open forum at the end of the meeting. So if there's anything that comes up, we can take your questions then. All righty. At this time, I'll pass it over to my supervisor, Lana Eggers, who's going to take us through some of the sustainability actions that are specific to Community First Choice.
Thanks, Eileen. And we have the correct links coming in here, so if anything is still not working for you, please don't hesitate to reach out. My name is Lana Eggers. I am the waiver administration and compliance, or waiver openness. I'm a manager over some of the waiver work and the CFC work at the HICPUF. Sometimes those long titles stick in the back of my throat. So I'm going to walk you through some of our sustainability actions that the department is currently undergoing. There have been several meetings that have been facilitated by our director, Bonnie Silva. So this information is not new. It's been presented in those meetings. This information is also actively posted on our HICPUF website. But because some of these sustainability actions do impact First Choice, we wanted to make sure that we brought this information to this group in particular, in case anybody is not aware of this information or would like some additional time to hear it. So, as many of you know, the governor released his budget on October 31st. That budget had a really big task of closing a multi-million-dollar budget deficit. Because of that, all state agencies, including HICPUS, have been working to implement cost savings measures to make long-term care and to make Medicaid sustainable. Part of these fiscal constraints are a result of some of the federal actions that are being taken. We also have limits on state revenue growth. There's a lot of reasons that we are in this budget deficit now. But what we're trying to do is to make conscious decisions on how we can ensure that our programs remain accessible to the most people on a long-term basis. So I'm going to go over those in a second, but I do want to draw your attention to the LTSS Medicaid Sustainability website. We'll have that link in the chat. We also will be providing information via the OCL newsletter. So if you're not already signed up for that, please make sure you're signed up for that for the most up-to-date information on these changes. We also have our OCL stakeholder engagement webpage. That has all of our stakeholder engagement opportunities. So for example, if we were to add some additional listening sessions with our director, Bonnie Silva, those would be listed on here. Many of those are register only because they are via Zoom, so we can have a larger capacity for folks to attend. So make sure that you check those out if you're interested in joining. And then we also have a stakeholder form. So we'll put this link in the chat. This is how we are hoping to receive a lot of the feedback that we are getting on these actions, because we have a tremendous amount of feedback, and thank you guys very much for participating in this conversation. We want to hopefully kind of direct it through one channel. Any way that you guys want to provide this feedback, of course, we'll take it. We'll take some in this meeting today. I'm hoping to have some time for open forum at the end, but this is a great way to provide that feedback. Okay, next slide, please. Okay, so there are several initiatives that impact community first choice. All of these are required to be implemented in the spring of 2026. The exact timing on when these will roll out, how they will roll out, all of that information is forthcoming. I understand that a lot of you have questions, you've submitted questions, you've asked those questions of our directors, and we don't have that information for you yet. So I do apologize that I will not be providing that information today, but our goal would be to disseminate that to all of our stakeholders at the same time. So please hang tight a little bit and we will have some implementation details pushed out. Make sure you're signed up for that newsletter. So first, we have an annual soft cap on personal care, homemaker, and health maintenance activities. What a soft cap means is that most individuals will be limited to the units you're seeing on the screen. So that's 10,000 units per year for personal care, that's 4,500 units for homemaker, and that's 19,000 units of health maintenance per year. Most folks will fall into an assessed need that those units meet their current authorized units, they meet their current assessed needs, but we recognize that some folks have a higher level of acuity and require more care and more hours to stay in the community. So there'll be an exceptions process, similar to some of the exceptions processes that we already have in place, where a case manager would request of the department to approve units in excess of these limits. So members can go over these unit limitations if there is a need to do so. The next one we have is a weekly limit of 56 hours per caregiver for a single member. This 56-hour-a-week limit is for the total number of hours provided across several services. So it's personal care, homemaker, health maintenance activities, long-term home health aid, and long-term home health nursing services. Again, that's for a single caregiver for a single member. If an individual provides care to more than one member, there would be extra hours available. I do want to clarify that the 16-hour-a-day limit for an individual caregiver that's currently in place for personal care, homemaker, and health maintenance will remain. And that limit is really for the health and safety of our members. Lastly, we have a 5-hour-a-week limit of homemaker if it's provided by a legally responsible person. Right now, this is a 10-hour-a-week limit, and we are dropping that down to 5 hours a week. If an individual has an assessed need for additional homemaker hours, a member can continue to receive those. They would just need to be provided by a different caregiver. That's the same with the 56-hour-a-week limit. That in no way restricts the services or the authorization that a member can receive. It just says that one caregiver is limited to that amount. And if somebody has a care need that's above and beyond that 56-hour-a-week, a secondary caregiver would need to come in and work those hours. Okay, next slide, please. Okay, so next steps in communication. Like you all know, we owe you a lot more information on how these initiatives will be implemented. So we will get that out to you as soon as we can. In the meantime, we have posted one summary of our stakeholder feedback that went up on November 18th. We are continuing to compile questions from stakeholders. We have received a tremendous amount of public comment for our 1915C waivers. We are compiling all of that, and we will be creating a frequently asked questions document for you all to have access to. Here's the link again to that governor's budget announcement comment form. And then lastly, there is one more listening session that's currently scheduled. That is for December 11th. As that relates to CFC, the only initiative on there is not one that I actually talked about today. It's about kind of restructuring rates. It's part of our budget process, not part of the sustainability options. So that one, if you'd like to attend, please join. Just a heads up, because we have so many stakeholders that would like to participate in those meetings, we are asking that you pre-register to provide comment, and it's on a first come, first served basis. So if you know you would like to provide comment on a specific initiative, please just make sure that you have registered so we know to call on you when we're up for public comment. Okay, and I see a hand, Megan, I'm gonna hold on just for a little bit longer. I'm gonna go ahead and get through the rest of these slides, and then we're gonna have some open forum time in the end. Okay. So getting to the implementation of these changes, we are going to need to make changes to our code of regulations. So as you know, we make rule changes when we make changes to the way that our services are delivered or anything like that. So we are making rule changes. These next two slides are going to run through the process that we will be undertaking for these specific rule changes. It's a really quick turnaround for our regulatory changes for April 1st effective date. Because of that, we are well underway already. You guys, many of you know that our 1915C waivers are currently out for public comment. I think we have a few more days on public comment for those waiver actions. We are also submitting a state plan amendment for CFC to ensure that both our waiver and our CFC services, since we have folks that are still in that transition period, that the language aligns across those two delivery options. We are moving forward with a pretty quick turnaround time with the February 2026 rule effective date. The reason that our rule effective date is before April 1st, 2026 is because case managers need to do their work a little bit earlier. We don't expect case managers to have the regulatory authority to change prior authorization for example, the homemaker limit, if somebody just wants to have that 5 hours a week provided by a legally responsible person. We don't expect them to make those changes on April 1st and then also go into effect on April 1st. So case managers need a little bit more time to begin that work. We expect that work to begin in February. So we will be running an emergency rule that will go to our medical services board in mid-February and become effective in mid-February. I understand that emergency rules aren't ideal for many of us. We much prefer to have the traditional rulemaking process. However, due to the time constraints of the executive order, that is where we are. Next slide, please. So the scope of these changes would be to clarify definitions, to update caregiver limits and service limits to comply with the executive order. For example, we are modifying the legally responsible person definition to add common law marriage. We're adding a new definition for age appropriate task standards for children. And we are adding a new definition for parental or legal guardian responsibility. So there are a lot of changes that we've talked through in this council meeting already. So you will see those coming in that rule packet, but you'll also see these new limits. While we cannot change the limits themselves, those are part of the governor's budget. We are seeking stakeholder engagement and stakeholder feedback on the language associated with those in rule changes. We want to make sure that it's clear. We want to make sure that it's operational. So please, we would like your feedback still. We are going to get to the rule drafts as soon as we can. We expect that we will have a rule draft for stakeholders in mid-December. So we'll get that to you. We'll be taking public feedback on those beginning in mid-December. They'll be sent out through that OCL newsletter. Again, that link that I had earlier in the presentation. If you're registered for that, that is how you will receive information on this rule draft. Next slide, please. So again, we're hoping to get it to you in mid-December and leave about a month of time for stakeholder feedback. This is a lot more time than we would typically have for stakeholder feedback in an emergency rulemaking process. We're trying to meet some sort of middle ground here where we can receive as much stakeholder feedback as possible under these truncated timelines. So stakeholder feedback will be due about January 12th, and that's to ensure that our rule packet is ready to go to the Medical Services Board ahead of our February date. Once our rules are effective through that emergency rulemaking process to ensure that case managers can begin that pre-work, we will then move into our traditional rulemaking process for a permanent rule. That will begin in April, and then we will have an effective date of our permanent rule in May. So we'll be going through the rulemaking process again. During that secondary rulemaking process, there will be more time for stakeholder engagements. Okay, I have one more slide here, and then we're going to go to open forum. Shifting gears a little bit, I know that many of you, myself included, are eagerly awaiting the difficulty of care ruling from the IRS. Unfortunately, we have not received an update on our ruling from the IRS in a little while. The staff working on our ruling were furloughed during the government shutdown. So there has been a delay in their ability to get that ruling out to us. Last we heard, that ruling is in clearance. So the federal government, similar to the state, has a pretty robust clearance process, and we are expecting to have a ruling soon. They know how important it is for the state to receive that ruling by the end of the year. Until the ruling comes in, TikTok has tried to release as much information as we can. There is currently some FAQ questions on our CFC website, so please feel free to revisit those. But we have also released the difficulty of care fact sheet for eligibility workers. The intention of this fact sheet is to help guide eligibility workers through conversations with members who are interested in the difficulty of care exemption and are interested in enrolling in CFC. As we have discussed in this meeting before, there are some kind of eligibility nuances that a member or a eligibility worker would need to know to make sure that that DOC exemption can remain in place if a member is also enrolling in CFC. So this fact sheet is to guide eligibility workers through that process to make sure that members have all of the information they need to be in the category they would like to be. This fact sheet is not intended for tax purposes or offer tax guidance. So please, if you have any tax questions, I know that we're getting up to the season here, please talk to a tax professional. I do want to note that this document is for county offices, and we don't expect case managers to know all of the ins and outs of this process. It's not a case manager's responsibility to guide members through that decision-making process. So please don't feel like this document out there is putting an additional burden on you, or we're asking you to understand one more thing related to eligibility. If you have any questions on difficulty of care, please reach out to the CFC inbox. I know there's a lot of unique circumstances, and we will do our best to help you work through those while we wait for the IRS ruling. Okay, that is what we have so far. I am gonna pivot to open forum. Before I take some hands, I was not monitoring the chat at all during that. So I'm gonna ask Eileen if there's anything for clarity that needs to be discussed prior to moving into our hands.
Hi, Lana, thanks. At this time, I think that we are working on getting all the chat questions answered. So I think we can pivot to hands, but I do see Cassie, you jumped on there. So Cassie,
I do just want to take a sec. There was a lot of confusion and multiple questions when it came to the caregiver limits, and questions of, okay, excuse me, how in the world does the 16-hour limit that is 12 hours a week, how does that comport with the 56 hours? So I tried my best to explain it in the chat, but really what we're looking at is a person can work up to 16 hours per day of providing those specific called out services. And we will do a more comprehensive job in the next set of regulations about what services are and are not included in that. So you can work up to 16 hours a day. Again, up to 56 hours a week. So doing that math, it's about 3.5 hours of work at that 16 hours. So what we didn't want to do is further limit and say you could only work an 8-hour shift, because oftentimes nurses or family caregivers work more than an 8-hour shift. We wanted to give that flexibility in how you staff and work a work week, but that cap of 56 hours is for the week in totality. So how you work those hours can be up to that 16 hours encompassed in that total of 56. So I hope I did not make that more confusing, but please, if that is not making sense, let us know, but trying to just help clarify how those two would work together.
Great, thank you, Cassie, for that. Okay, it looks like Molly was up first. Molly, do you want to go ahead and come off mute?
Hi, good morning. Can you hear me okay?
Sure can.
Okay. So I know all of this is really hard. It's difficult for everyone. I have some real concerns about the cap on the weekly hours for a member for a single caregiver. So sort of all the things that are popping up in the chat. So what you're saying is one individual caregiver is still safe to provide 16 hours a day, and a member, even if we're going by the soft cap and to keep it simple, 13 hours a day of health maintenance. So not even considering that that member who needs 13 hours probably needs some number of homemaking as well. So the money saved isn't just by limiting what a member can receive under a soft cap and what a caregiver can safely provide. The money saved is only if you're counting on a member not being able to staff the care that's been justified, because their available caregiver who still is able to provide 8 more hours of care to someone else just can't provide it to them. So that seems cruel, really, or just really poorly thought out. I mean, you're kneecapping an existing and already strained workforce. I was a case manager in Clear Creek County for many years. So it's close to the Denver metro area, but from a caregiver pool perspective, like really remote. Members, case managers work really hard to find caregivers, whether it's an agency who's willing to go up there or an individual caregiver and backup caregivers for CDUS. Under this change, those precious gem caregivers that are making it possible for someone to stay home are no longer able to provide all their available caregiver hours to that one particular person, but they can do it for someone else. So in the end, you're not really saving money because more people are going to have to go to a nursing home while you have available caregivers just kind of shrugging on the sideline. So this one's hard for me to make sense. You have the caregivers, you'll pay the caregivers, but just not for this one person. Like they can't get it all. So everyone sort of gets bits and bobs of things, but not everything they need. That's all, just a comment. I hope this one gets looked at a little more closely.
Thank you, Molly. I do appreciate you coming off mute and sharing that perspective. Really appreciate that real world consideration. Okay, let's go to Megan Bowser.
Hello, Megan Bowser with Family Voices, Colorado. So trying to focus on what's within maybe the people here's purview that I know. I have lots of frustrations with all the caps and all the things, echo many of Molly's feelings about that all. I think the point I want to make right now, though, is this is really in the weeds. All these number caps on hours and services and 56 and 16 and 10 and 12, right? Like there are so many numbers being thrown around. And so the lack of consistency in what we see in different presentations and different documents is really, really impactful for the people actually receiving these services and trying to figure it out and plan. And so in the inconsistency in the implementation and what case managers are telling and all the things around the place, it is already really confusing to think about 16 days for any number of member or 16 hours for any number of members, but 56 for a single member, if the services that were included in those were abundantly clear, but they're not. And so I hear a lot like, yeah, we need to work on this. And I want to emphasize how really, really impactful and important it is, even though it seems like a really in the weeds, nitpicky thing. It's not when you're on the ground actually providing these services. So that's one piece of my feedback. The other question that I've been trying to ask and can't get an answer from anybody on is whether CFC services, since CFC is part of state plan, fall under EPSDT rules. Does anyone here know the answer to that question by chance?
Do you mind clarifying a little bit more what you are asking there?
Yeah, EPSDT is
a specific situation that you want to run by us.
Yes. Well, so like the gist of EPSDT is for kids up until the day they turn 21, anything that is medically necessary has to be available to them, and there can be no hard caps on any particular service and such too. So I know that the caps on homemaker and personal care and health maintenance are soft caps, not hard caps, but I'm still trying to figure out if those services fall under EPSDT so that we can ensure that those at least up until age 21 are absolutely receiving the services that are guaranteed to them under EPSDT rules, even if those services are in CFC. And EPSDT applies to state plan services, so it applies to like physical therapy and wheelchairs and those sort of things, but CFC is this like weird kind of state plan, kind of not, and I can't figure out if it falls under EPSDT rules or not.
Okay, thank you for clarifying. I'm going to give it a shot and then welcome any of my colleagues to jump in if they would like to. So CFC services are, I would say, kind of a branch of long-term care that would be very similar to what's provided under a waiver, which would not be classified as a medically necessary service. So no, I do not believe that it is under EPSDT. Does anybody have anything that they'd like to add to that? Or Megan, please go ahead.
So pediatric personal care provided under state plan benefits would be under EPSDT rules, but personal care provided under CFC would not be under EPSDT rules.
So what's the goal? And help me understand the goal. So I know that you stated that, we understand that there are no hard limits. We made a very deliberate choice to not have any hard limits under CFC because it's an entitlement program. It's part of our state plan. So we don't have hard limits or hard caps. And we're talking strictly about the services provided under CFC. So if a child has a need for a service that's authorized under CFC, they would have access to that service under CFC. We're not limiting it in the way that some of our waiver services were limited. So is there a goal is there a different goal other than making sure that services are available? I think I could still use a little extra context.
Yeah, I mean, ultimately, I'm trying to figure out like what's the legal standing of this too, because there's gonna be people that are gonna need to appeal when they hit that soft cap and the exceptions process is denied. So ultimately, I'm trying to plan for what happens in those situations if somebody really needs 10 hours a day of personal care, but they're capped to 6.8 hours per day, and they apply for an exception and it's denied. Like, what's our legal standing is what I'm trying to figure out. Does that fall under EPSDT still or not?
Okay, that's very helpful. Thank you, Megan. I am not here to give legal guidance, as you could probably guess. So I am going to probably have to hunt this question a little bit. But Kidron, feel free to weigh in. I see that your hand went up.
Yeah, I'm happy to take that question. I mirror Lana's comment and start this by saying we're not giving legal advice in any way, shape, or form, but our current advice from our legal division is that if a CFC service was denied through the service planning process with your case management agency, that we would anticipate that notice of action would be given to the member to appeal that action of denial. So we do anticipate there being an appeal process. There's no correlation to EPSDT services though. It would follow the same appeal notice of action process as our home and community-based service waiver appeal process would look like.
Okay.
Does that help, Megan?
Yeah, I mean, if you guys could get clarification from the legal team at HICBUF, that would be super helpful, because it's really important for us to know in those appeal processes whether there's a distinction between what the rights guaranteed to somebody under 21 versus over 21 are within that process. Like, that's an important distinction for us to understand.
Yeah, we're happy to have that question be part of our ongoing conversations with our legal division and the Attorney General's office. Happy to take that.
Okay, thank you, Kidron. I needed to phone a friend there, so I appreciate you jumping in with that. And then Megan, I know that you had an earlier comment about inconsistency of information. And is there anything that you want to follow up with the email about what's inconsistent? It would be helpful to have. We did our best to take these slides kind of verbatim from previous presentations to ensure consistency of information. So if there's anything that you want to make sure that we follow up with outside of this meeting, I want to make sure we have time for some additional folks to comment. I would welcome that feedback.
I did it in the chat, so.
Okay, thank you so much. Okay, we'll move on to Deborah. Deborah, if you're talking, I am unable to hear you. I see you now. No. I'm still unable to hear you. Would it be okay, Deborah, if I moved on to Tara and then came back to you right after that? Okay, great. Thank you. All right. Tara, if you want to go ahead.
Hey guys, my name's Tara. I'm with About Kids Home Care. I'm just trying to understand how to explain this to our families. Can you help me understand why the 56 hours a week is limited to one caregiver when you guys are still willing to pay up to the 112 hours? So we have a lot of single family homes that, obviously can't work because they have kids that they're providing full-time care for. And while we as an agency can support the other hours, that the patient needs support in, why, if you guys are willing to pay out the 112 hours regardless, why can't that not go to that single family provider? And just to kind of piggyback on that as well, even if there's other, let's say other family members in the home, legally responsible adults, not all of them are certified to provide that level of care. And so we're looking at potential more schooling, if they're even able to do that. We have lots of families that have, communication barriers and whatnot. So I think there's just a lot more that goes into this, and it's really hard to explain to a family why the state is willing to pay out 112 hours, but not fully to them.
Thank you for that feedback. I appreciate the feedback, and we will certainly take it back.
I mean, is there any guidance that you guys can give me on explaining that to families? I mean, we've got a lot of families. I think a lot of other agencies can speak across the board where they're in complete panic. I mean, this is their quality of life. And, they're not only wondering how they're going to pay bills, but how they're going to find care so they can work to compensate for that. So it's really hard to explain when you guys are saying that you're going to pay that out regardless, but not to just the one person that has been paid. So I'm just looking for a little bit more guidance on how to explain that.
Thank you, Tara. I appreciate that question. We will certainly take that one back. I'm not prepared to give an answer on that one today, but we will make sure that it's included in our forthcoming information. Thank you. Okay, Deborah, would you like to try again? Nope, I'm still unable to hear you, Deborah. If you're comfortable typing in the chat, happy to have your comments there or email us or yeah, so apologies that we can't get this working for you today. If you feel like coming back on, I'll check in with you after Bryce. Okay, all right. Bryce, please go ahead.
Hi, can you hear me?
Sure can.
Awesome. Bryce Rafferty with CCDC. I am just wondering, with these task standards and the time units, I mean, they are, well, I guess I have two questions. Are they tethered to national or state standards? And if so, what and how are they determined? And then two, are we sure that, because I just took another look at the nurse assessment Excel spreadsheet that's on the nurse assessor website, and I'm not really seeing any of these task standards there. Considering that there's been a ton of need, or large need for deviations from HMA recommendations, and we have these task standards. I'm also wondering, like, are these being used and streamlined across Telegen and CMAs? And if so, are they, what are they based on, and where can I find how these were calculated? And the other thing, just really quick, is like, we've heard that some nurse assessors have issues with like going over these. So there might be some confusion about like whether or not these are actually hard caps, and assessors having issues like modifying times to go over them.
Thank you for those comments, Bryce. Appreciate it. I'm going to take a swing and then I'll defer to my colleagues here. When we went through the recent emergency rule process, there are some additional documents that are now available, or some updated documents that are now available that supplement the DCSC. Those are all linked in the DCSC that a case manager uses, and they are standardized for kind of use across all populations. So those might meet the need that you're asking for, but I'm also going to call on Danny and see if Danny has any other information to share.
Thanks, Lana. Yes, you're absolutely on point that this is tied to the emergency rule that was run in November. And then Bryce, I just want to reassure you the norms and task standards are based on national standards, and they're based on research and recommendations provided to us by University of Massachusetts. They are not wildly different than what has previously been provided. They're more so just more broken down. We currently are in the process of issuing operational guidance, and we will be providing the direct care services calculator with the updated age appropriate task standards in the next week or so. But I do want to just clarify that these are case manager tools. They are a guide to support the assessment process, as well as like appropriate authorization management. The direct care services calculator has previously also been a case manager tool. So just want to clarify that piece, but there will be a memo coming out in the next week or two. I think it's slated for next week, honestly, that will have the updated information as well as the updated direct care services calculator with the clarified task standards.
Elgin has these same standards.
Yep, these are the standards that are applied universally for the services under CFC. So the task standards are applicable for anyone who's authorizing or assessing for the service, or excuse me, authorizing or assessing for IHSS, CDAS, personal care, or homemaker services.
Thank you, Danny. I appreciate that information. Okay, we have about 2 minutes left in the meeting. I'm going to try Deborah one more time, and then we'll go to Lauren. Deborah, do you want to give it one more go here? No, we can't hear you still. Feel free to email us or put anything in the chat. We would love your feedback. Sorry about that.
Nina,
Okay, Lauren,
she
please
just
go
put it in. She just put it in the chat.
Okay, great. Thank you.
Hi, Lana.
All right, Lauren, please go ahead.
Hi, can you hear me okay?
Sure can.
All right, so just want to ask HCPF to consider one more thought related to the 56-hour cap per caregiver per week per client. That there's an unintended consequence to that cap that is related to the tightness of the labor supply right now for direct care workers. So that cap is going to cause families who currently have a primary caregiver working above that cap to have to identify or have their agencies identify secondary caregivers to fill the additional hours above the 56 hours. Because of the tightness of the labor supply, it is going to be very, very difficult to find those caregivers, especially in rural parts of the state where they really will not exist. The end result and the unintended consequence is going to be that care and access to care will fall below the par. And if agencies are not able to provide that level of care, then the end result is going to be forcing families and forcing members into institutional care at much higher cost to HCPF. So I ask you to please consider that unintended consequence and help us find a way around that. Maybe it's through the exception process, but we've got to find a way to avoid pushing people back upstream into nursing home care.
Thank you so much, Lauren. Appreciate that feedback. We will certainly take that back and provide some responses in our communication that we posted on the website. I know this has been a little bit of a tough call. I think that a lot of these changes are not ideal and they are tough and challenging for families and stakeholders. So I just want to say thank you all for sticking with us through this call, and I appreciate all of your feedback. I know we can't give a lot of answers right now, and we will get those to you as soon as we can. So just really appreciate you being here today. You know, we're doing the best we can to implement the governor's executive orders in a way that is thoughtful and continues to meet the need of our long-term care population across the state today and in future years. I'm going to hang on for just a little bit longer. I know that we might still have some questions in chat that we are getting through, so I'm going to leave the line open for just another minute. There are some contacts on this webpage. Again, it's that governor's budget announcement stakeholder form. We have the ADA accommodations link there. And of course, the CFC inbox. If you're just not sure where to go, you're welcome to go there and we can direct it in the best way that we can. Okay, I'm going to go ahead and leave it open for just a minute. But again, thank you all. And I hope you guys all stay warm and safe on this snowy day.
Deborah, are you still on the line? If you are, I know your audio isn't working, but if you could come off camera. Okay. I'm seeing your question now. There was a slide about this, but for your question about difficulty of care, and we have a fact sheet that I think might be helpful for you. Do you have an email that you could put in the chat and I can get that over to you? Thank you. I will send that information over. Thank you.
Okay, thank you for that. Thank you for that, Maddie. I'm going to go ahead and close out the meeting and we'll see you all next month. Bye now.